The room went quiet when they opened her. Not the dramatic silence of a crime scene. The specific professional quiet of a forensic pathologist who has performed 3,000 autopsies and has just found something that stops her mid-motion. Margaret Holloway was 53 years old. She arrived at Cedars-Sinai by ambulance at 2:47 a.m. on a Thursday. Vomiting blood, she was in surgery in 20 minutes. Dead by 4:15 a.m. from a stomach that had ruptured catastrophically from the inside. Her family told the ER team she was healthy. Her internist of 14 years had examined her 6 weeks earlier and called her one of his healthiest patients. She had no pain, no weight loss, no symptoms. When the autopsy opened her stomach, Dr. Patricia Yuen, the forensic pathologist assigned to the case, found a cancer that had grown through the full thickness of the stomach wall, invaded the surrounding tissue, and spread to her lymph nodes. She wrote the estimated origin in her report. 11 years ago. 11 years inside a woman who passed every physical, who ate normally, slept normally, lived completely normally until the morning she called 911 from her bathroom floor. And before you understand how that is biologically possible, before you understand why this specific cancer is so extraordinarily good at hiding, there is something about how Margaret's cancer started that you need to hear. Because it started with something that half the people watching this video are currently carrying inside them right now. And almost none of them know it. 800,000 people die of stomach cancer every year. It is the fourth leading cause of cancer death in the world. In the United States, the 5-year survival rate is 36%. Not because the cancer is untreatable, because by the time it is diagnosed, it is almost always already in a late stage. Japan screens its population for stomach cancer starting at age 40. Their 5-year survival rate is 80%. Same cancer. Different detection point. 44 percentage points of difference in who survives. Margaret Holloway lived in Los Angeles, not Tokyo. In Los Angeles, no one screens for stomach cancer in people without symptoms. In Los Angeles, the cancer Margaret had, diffuse-type gastric adenocarcinoma, has no early symptom that any primary care protocol is designed to catch. It hides. It grows. And then one morning at 2:47 a.m. it stops hiding. But what was hiding with it, the organism that started the process 11 years before the rupture, is the part that changes everything about this story. And it changes it for a reason that is going to make you want to ask your doctor a question you have probably never asked before. Hold that thought, because first you need to understand what was found when investigators looked back through 11 years of Margaret's medical records. After the autopsy, Dr. Yuen's findings triggered a case review. A hospital administrator pulled 11 years of Margaret's medical history, every annual physical, every blood test, every complaint she had ever logged with her doctor's office. The records showed something that individually meant nothing, together meant everything. 2012. Margaret called her doctor's office complaining of occasional bloating after meals. The office notes, patient reports intermittent gastric discomfort, advised dietary modifications, no further workup. 2014, Margaret's annual blood work showed mild anemia. Her doctor noted it, attributed it to dietary iron, recommended a supplement. 2016, another mention of bloating, another dietary recommendation. 2019, her iron levels were still slightly low. Her doctor noted it as chronic, stable, benign. None of these entries, in isolation, warranted a scope. None of them triggered any protocol that would have looked inside her stomach. Together, mild anemia persisting for years, chronic bloating, a woman in her mid-40s, they formed the exact clinical picture that Japanese gastroenterologists are trained to treat as a signal that requires investigation. In America, there were 4 separate chart entries that never became a conversation. But here is the detail in Margaret's records that Dr. Yuen noticed last, and that turned this from a tragedy into a question that needs an answer. In 2013, Margaret had been tested for something, a specific blood test, and the result had come back positive. Her doctor had noted it, prescribed a 2-week course of antibiotics, and closed the chart entry with the words, "Treatment completed, no further follow-up required." The test was for Helicobacter pylori. And what her doctor did not tell her, what the 2013 guidelines did not require him to tell her, and what the 2024 guidelines still do not consistently communicate, is what H. pylori, left incompletely treated, does to a stomach over the following decade. Helicobacter pylori is a bacterium. It colonizes the lining of the human stomach, an environment so acidic that almost nothing survives there, by producing an enzyme called urease that neutralizes stomach acid in its immediate vicinity, creating a protected microhabitat in the mucus layer of the gastric wall. Half the world's population carries it. In the United States, approximately 35% of adults test positive. In populations with lower socioeconomic access to early childhood sanitation, where the bacterium is typically acquired in childhood through contaminated water or food, the prevalence reaches 70% to 80%. Most people who carry H. pylori never develop stomach cancer. But the World Health Organization classified H. pylori as a Group 1 carcinogen, the highest classification of cancer-causing agent, in 1994. The same classification as tobacco smoke. The same classification as asbestos. The mechanism by which it produces cancer is not a sudden event. It is a 30-year process. H. pylori triggers chronic inflammation of the stomach lining, gastritis. Chronic gastritis, sustained over years, causes the stomach's normal glandular cells to be progressively replaced by cells of a different type, intestinal-type cells, in a process called intestinal metaplasia. Intestinal metaplasia, if it progresses, evolves into dysplasia, abnormal cell architecture that represents the final step before malignant transformation. This cascade, from infection to gastritis to metaplasia to dysplasia to adenocarcinoma, takes, on average, between 20 and 40 years in the intestinal-type cancer. In diffuse-type gastric cancer, the type Margaret had, the timeline is different, faster, more aggressive, more silent, because diffuse-type cancer does not form a visible mass that bleeds or obstructs. It infiltrates the stomach wall laterally, like fingers spreading through the tissue, without creating a lump that a scope would easily identify in early stages. It grows in the walls, not in the space. Which is why 11 years of a completely normal-appearing stomach lining, normal enough to reassure any physician who had actually looked, was nonetheless a stomach in the process of being destroyed from the inside. Wait. Because there is a question buried in what you just heard that most people miss the first time through. If H. pylori takes 20 to 40 years to cause intestinal-type cancer, how did Margaret's cancer start 11 years ago? The answer is in her genetics, and it leads to a second discovery in Dr. Yuen's report that changes the entire story. Among the findings in Margaret's autopsy report was a tissue analysis that included genetic sequencing of the tumor. The sequencing found a mutation in the CDH1 gene, the gene that encodes E-cadherin, a protein responsible for cell adhesion in epithelial tissue. CDH1 mutations are associated with hereditary diffuse gastric cancer syndrome, an inherited condition that dramatically accelerates the development of diffuse-type gastric adenocarcinoma and increases lifetime risk of the disease to between 70% and 80%. Margaret had never been tested for CDH1 mutations. No one had ever asked about her family history in the specific way that would have surfaced the information, because her mother had died of what the family described as stomach problems at 58, and her maternal uncle had died of abdominal cancer at 61, and neither of these had ever been formally investigated as potentially genetic. The combination, an inherited CDH1 mutation accelerating the diffuse-type cancer, and H. pylori infection providing the chronic inflammatory environment that the mutation needed, had compressed what might have been a 40-year process into 11. And here is the thing about CDH1 mutations that the family was not told after the autopsy, because no one is legally required to proactively tell them. Margaret had 3 children. Each of them has a 50% probability of carrying the same mutation. Hereditary diffuse gastric cancer in CDH1 mutation carriers is treated with prophylactic total gastrectomy, complete surgical removal of the stomach, before cancer develops, because the cancer, when it develops in these patients, almost always develops before it can be detected. Margaret's 3 children had not been tested. They had not been counseled. The autopsy report went to the county medical examiner's records. The family received a death certificate. The cancer that killed their mother might be building in one of them right now. Here is what the research shows about the preventability of what happened to Margaret. In 2020, the American Gastroenterological Association published a clinical practice update co-authored by doctors Mimi Canto and William Grady of Johns Hopkins and the Fred Hutchinson Cancer Center, recommending systematic screening for gastric premalignant conditions in high-risk populations, including individuals with H. pylori history, individuals with a family history of gastric cancer, and individuals of East Asian, Latin American, or Eastern European descent, where H. pylori prevalence is highest. The recommendation exists. It is in the literature. It is endorsed by the AGA. It is followed by a minority of primary care physicians in routine practice because it is a recommendation, not a mandate, and because the reimbursement structure for endoscopic surveillance in asymptomatic patients in the United States creates a financial disincentive that the clinical recommendation does not address. H. pylori eradication, when fully confirmed, not just treated but confirmed eradicated by a follow-up breath test or stool antigen test, reduces the risk of subsequent gastric cancer by approximately 54%, according to a meta-analysis published in Gastroenterology in 2020. Margaret was treated in 2013. She was not given a follow-up test to confirm eradication. The chart note said, treatment completed. It did not say, eradication confirmed. Whether the H. pylori was actually eliminated, whether the 2 weeks of antibiotics fully cleared the infection, or whether a resistant strain survived and continued its work for another 8 years alongside the CDH1 mutation is a question that can no longer be answered. The stomach that held the answer no longer exists. Margaret Holloway did everything she was supposed to do. She had a primary care physician. She attended her annual physicals. She reported symptoms, the bloating, the fatigue, and received recommendations that were clinically appropriate in the context of each isolated visit. The system treated her symptoms one at a time. It never looked at them as a sequence. And when the H. pylori was found in 2013 and treated, the instinct to close the chart, to mark the problem resolved and move forward, was the instinct that left the door open for 11 more years of unmonitored risk. The treatment that was supposed to end the story became the moment that sealed the silence. Because confirmed eradication would have required a follow-up appointment, a follow-up test, a follow-up chart entry that connected 2013 to 2014 to 2023. Instead, the chart entry in 2013 was complete in itself. The problem was documented as resolved. And whatever was still growing in Margaret's stomach was no longer anyone's assigned responsibility. What medicine learned from Margaret Holloway, from the AGA guidelines that were published after cases like hers, and from the growing body of research connecting H. pylori eradication to gastric cancer prevention, is that a cascade of preventable failures in standard American primary care practice can produce a death that looks inevitable but was not. What Margaret's family never received was the conversation that should have happened in 2013, or in 2014, or in 2016, or in 2019. The conversation that would have connected the mild anemia to the H. pylori history to the family deaths that sounded like stomach problems, to the genetic risk that her children now carry without knowing it. Her 3 children do not yet know they should be tested. The chart said resolved. The cancer disagreed. The difference between a stomach cancer that is found when it is treatable and one that is found in an autopsy is almost always a single conversation with your doctor, one that the system does not prompt, that you have to initiate. If any of the following apply to you, bring them explicitly to your physician at your next appointment and ask for a H. pylori test if you have not had one, or ask for a follow-up eradication confirmation test if you were treated but never confirmed clear. You are of East Asian, Latin American, Eastern European, or African descent, populations where H. pylori prevalence is above 50%. You have a family history of stomach cancer, stomach problems, or abdominal cancer in a first-degree relative who died before 70. You have unexplained chronic mild anemia. You have persistent bloating that dietary changes have not resolved. If you have been treated for H. pylori, ask specifically, was eradication confirmed with a follow-up urea breath test or stool antigen test? If the answer is no, or if you do not know, ask for that test now. It takes 15 minutes. It tells you whether the bacterium is gone or whether it is still there. And if your family has a history of stomach cancer in multiple first-degree relatives, ask about genetic counseling for CDH1 mutation testing, not for yourself only, for your children, for your siblings, for everyone in your family who shares the biology you share. Margaret's cancer began 11 years before the morning that ended everything. The test that would have changed the story cost less than $100. It was never ordered,